Hello, and welcome to another episode of the Melbourne Athletic Development Podcast. Today, we're very fortunate to have Dr. Manuela Besomi with us. Manuela, thank you very much for being here today.
Thank you, James. It's a pleasure to be here.
Jack.
Oh my gosh. Jack.
Even better, thank you.
But that's okay, that's not really important.
Very good.
So, to give this podcast our listeners a bit of context of the conversation, can you introduce who you are and what you do?
Yeah, absolutely. So, my name is Manuela. I'm a physiotherapist by background. I'm from Chile. And I moved to Australia in early 2017 to do my PhD in the University of Queensland, where I'm currently working. And my PhD was about understanding the methods that we can use to measure the in vivo the tissue. Oh my goodness, sorry.
That's
So
all right.
the in vivo measures that we can use to estimate the physical capacities or the physical properties of tissues, so such as the tibial band, and also providing consensus-based recommendations on the use of electromyography or CD or EMG through the Consensus for Experimental Design in Electromyography or CD project, which I'm currently coordinating as well. So at the moment, I work as a research fellow at UQ, and I'm coordinating a big project, NIH-funded project, looking at understanding the risk factors for low back pain flares. So we're using a range of different methods to understand how pain fluctuates in people with low back pain in their real world. So that's pretty much what I'm doing in terms of research. And also I'm very passionate about running and running injuries. So I also lead a group of clinicians and researchers back in Chile that basically contribute to understanding of how to manage and prevent running injuries.
Very cool.
Can you actually elaborate a little bit more what your PhD was on? Because we hear about things like EMG a lot within the physiotherapy research.
Yep.
And I feel like there seems to be a lot of confusion about what EMG is and what it tells us, because from my understanding of EMG, it can obviously give us certain messages, but I was interested to hear a bit more about your thoughts on it in general, and particularly you mentioned about measuring physical properties. And does EMG give us indications of physical properties, or is it more just like the neural activity?
Yeah, so when I say physical properties, I meant more like surrogate measures of stiffness using shear wave elastography, for example,
Yes.
ultrasound-based measures. But particularly for EMG, in like very simple terms, because it's not a simple tool, it basically measures the electrical activity from your muscles. So it's a neuromuscular measure. And what we did in my PhD and what we're actually currently doing at the moment is trying to, because there's so much information about like EMG, how to do it, how not to do it, like what sort of, how to place electrodes, how to normalize the amplitude. Like it's just so much there that it's very hard to follow like proper recommendations or like what sort of like decisions you should make when you're planning, for example, an experiment. So the problem is that if you don't really design your experiment to answer your research question, you might actually get results that are not appropriate, and you're actually misleading or misinterpreting the results, and therefore, like for example, the clinical recommendation. So a lot of the exercise-based studies that are based on EMG might be flawed because if you didn't apply the right method, for example, to normalize the amplitude of the EMG signal, you cannot actually interpret the signal in that right way. So that's why we developed the CD project, which is the Consensus for Experimental Design in Electromyography, which is an international initiative which aims to guide the decision-making process in the analysis, interpretation, and planning of EMG studies. So far, we have published 6 decision-making matrices with different topics that are relevant for EMG. So, for example, within my PhD, we published the electrode selection, how to select your electrodes for the best application for a specific experimental context, and also recommendations around how to normalize the amplitude of the EMG signal. So it really depends, like what you want to achieve. How do you manage or analyze your EMG signals and data. And we also published all the 4 or 5, like terminology, high density surface EMG, single motor unit, a checklist, like a bunch of other things that are relevant for EMG.
What can EMG actually tell us?
Yeah, so good question. So it really depends. I'm gonna say depends because it depends on how you apply it and when you use it. But in general terms, it tells you the whether a muscle is actually firing or not, right? Like it's the electrical activity. So you can interpret in simple terms the amount of the activity that you're measuring with all the limitations that will have, like like depending on where you place the electrode, which sort of portion of the muscle you're measuring, etc. It can also tell you when a muscle is on or off, and it can also tell you about the pattern of activity, right? So it's for example, in a dynamic task like running, you can see like a muscle is on and off, and how the pattern changes throughout the task. It might also give you, we could also measure more complex things like synergies, which is a combination of muscles that work together to achieve one task or one movement. That's a bit more complex. We also use EMG to understand single motor unit activity. So for that we use other methods like high density surface EMG or fine wire EMG to actually go into the motor unit. So firing rate, so when a muscle is firing, or the recruitment of recruitment of a motor unit. So you can get all sort of different neuromuscular features of your musculoskeletal system using this technique. It can definitely not tell you, it wouldn't really tell you anything about how much force an individual is doing. You can estimate the change in force from the change in amplitude of the signal. But the biggest, I think, mistake that we see, at least in the sports science field, is that we try to estimate, or we try to interpret EMG amplitude as a surrogate measure of force, and actually cannot do that.
Yeah.
So that's, I guess, the biggest issue.
Yeah, I think that's really important to emphasize, because I think a lot of people will look at a study, see that this particular exercise increases EMG activity of a particular muscle, and associate that with an increase in the mechanical force being exposed at the tissue level. But the problem with that is, particularly from an exercise prescription standpoint, is if that's not the case, are you applying enough mechanical tension to create adaptations that you desire?
Yeah, that's the biggest, I think, problem.
The other question I have to you about EMG is there such a thing as a normal EMG pattern? Because I think of, like, and obviously you work at the University of Queensland, you've done a lot of work with Paul Hodges, and obviously him, along with like Gwen Jarl, particularly in the 90s, 2000s, did a lot of work of looking at changes in EMG behavior in people with, say, chronic back pain or neck pain. But it's something that I've often thought about of, is there such a thing as normal, so to speak? Because I think about, say, and running is a good task, or lifting, there's a lot of different variables to consider about how I lift versus, say, you. And that's going to be reflective, I would have thought, in the neural signature as well.
Absolutely. And I think there's a very nice work done by Francois Hook from Nantes University. They did, I think they measured, could be wrong, but about like 80 people, and they had them either cycling or running, and they repeated the measurements, I think, said like 1 or 2 weeks later. And what they found was that participants have like a very unique signature of movement. So the variability between participants was massive. But within the person, you have a unique signature. So if you're not in pain, for example, and you don't change your behavior, the way that you move actually should match, like, if you measure the same movement over time. So that's pretty interesting, because that tells you that you could potentially identify someone based on their own signature of movement. And we could think that, of course, like pain or any other condition might change your own signature. But if you compare between individuals, it's really tricky. That's why we need like lots of people to average the data and actually see if there are differences in between groups of participants. Yeah.
With that in mind, is it possible to use that signature and track that across that same person in a similar task to get an identification of, say, fatigue patterns and what actually happens with that individual? Something that we've been talking about a lot is more in a global sense, this idea of central nervous system fatigue. And I think it's not well defined, and a lot of people aren't potentially using measures like this as some sort of correlate, because to me, the actual neurological activity that's happening at the tissue level is probably a good marker to know, are they actually fatigued from a nervous system point of view. Is this something that's possible that you could kind of track within that individual and say, okay, your signature looks similar, but when we know you get fatigued, this is the pattern or this is the amplitude that changes? Or am I extrapolating too much there?
I think, well, fatigue is a big beast, and I haven't done much work in fatigue. Like, I think it's just such a big thing. Like, and we don't really, as you said, like, we don't really understand what's the mechanism behind. We know like a couple of things that could be affecting, like central and peripheral mechanisms. There's some work done by Eduardo Martinez Valdez from the University of Birmingham in the UK, and they did like motor unit analysis, and they tracked, really had like a strengthening program over time, and you can actually see improvements in motor unit recruitment, de-recruitment, and firing patterns, so firing rate, with training, which is pretty cool. I think that was the very first time that someone did that in terms of like a neuromuscular, like a better proxy of what's happening with your neuromuscular system in terms of strengthening adaptations, right? In terms of fatigue, there are protocols that you can investigate, and the problem with fatigue is just it changes your EMG signal in a way that it's hard to actually interpret it. So you don't know.
Sorry to interrupt, but is that therefore then a correlate that someone is fatiguing because as you said, their signature seems to be similar? But once they do reach, say, maybe a certain threshold of fatigue, then all of a sudden it doesn't look like their normal signature. Would that be, again, am I oversimplifying that? But is that possible that you kind of say, okay, your normal signal looks like this, and now all of a sudden it doesn't look like that? Potentially one of the mechanisms causing that is a fatigue input.
Potentially, yes, we could say that, but it's a really hard thing to study, and I don't think we have all the answers yet. Yeah,
and that seems to be the thing that comes across from my understanding of looking at this topic of motor control or sensory motor control and EMG activities. EMG gives us a proxy about what's happening in terms of the neural activity, but it doesn't necessarily give us any indications of what is causing changes in it, because as you mentioned then, fatigue is one. I know there's been some research published looking at changes, say, in tendon stiffness that influences EMG behavior. I know obviously Paul Hodges has been doing a lot of work of, the animal models are looking at changes in the erector spinae following like a disc lesion, where you see an increase in connective tissue around the muscle spindles, which is obviously going to influence the neuromuscular signature as well. So it seems that I get the impression that EMG we have to look at as giving us an indication of seeing changes in the motor control or sensory motor patterns, but may not necessarily give us indication of what's particular variable or factor is causing that change.
Well, it's just one piece of the whole puzzle, right? Like, and as I said, like, it's so hard to really to interpret EMG over time. There's so many things that could go wrong. So I don't think, at least I haven't seen a study that has looked at like all the different, measures or factors that could contribute to this change that you're talking about. So we're talking about them like they're like muscle, like even within the muscle. So you have the neuromuscular, but then the muscle morphology, that sort of thing. Like we're not a 2D system, it's a 3D system. So that's also affecting the capacity to produce force. Tendon is a whole beast. Within the muscle spindles and all that. Fascia is another beast. So I don't think we have like the answer to that, but definitely agree that EMG is just a way of like a looking at your neuromuscular control and system, and we just need to be mindful of like when we interpret that data, we just need to be cautious and not over interpret. Yeah.
Can I ask? You mentioned there the idea of a much more of a 3D model. Can you explore that a little bit, because it's something that has caught our attention over the last little period, and it's something that I think is very hard for people to conceptualize, because we see anatomy and even functional anatomy is very much being this 2D structure, but it's not really what is going on. It is a little bit more complex than that. And I know that's a very big question, but if possible, can you give us a little bit of an idea of what you're starting to see in how this does adapt and function in a more of a 3D pattern?
Yeah, so again, like, this is not my area of work, but people that I know that have been working on, there's a PhD student here, and also a researcher from Brussels. They've been looking at like, the first thing is, like, there is a huge variability between individuals. So that's the first thing. Like, we just need to first acknowledge that the shape of a muscle will differ between people. And second, whether when you contract, like, the muscle fibers will change depending on the shape, right? And in some portions of the muscle, you would have like a different change in the 3D behavior, right? That will be different. So it's quite complex in terms of, like, when you look at the studies and we interpret muscle force, for example, from one muscle fiber, it's really tricky because the muscle is not that, right? And there's some very interesting work done by Jeroen Ailes from Brussels that they actually measure this in people, like, between legs, and they showed that, like, the muscle fiber length is different when you look at different portions of the muscle. The 3D shape is also different. Like, there's so many factors that are affecting this. So I think when we think of, like, more like in a clinical or application, like, as a physio, I've always been encouraging people to, if you're going to train a muscle, just try to do it, like, in different, for example, range of motion. So, like, think of, like, a muscle, say, contracting in a 3D way. So if you move in one direction, that will affect, like, the other structures. And so you just need to train yourself in thinking of a 3D system.
Yeah,
I hope that makes sense.
Well, I was actually just going to say too, because and you've mentioned a couple of other topics that we need to touch on. One of them being fascia, and you're talking about the dynamic nature of muscle. I think of things like muscle architecture. And there's all these studies that are looking like a 2D ultrasound of here's the fascicle length. Yet, if you look at some of the research, I know the surname of the authors is Roberts and Azizi and Eng, of all the dynamic muscle architecture work, that depending on the type of contraction, you can actually see changes within the fascial sheets that influence then the angle of the fascicles to ultimately put them in a position where they are optimized to produce either really high force or really high velocity type contractions. And I think that, to your point, it's something that when you start to look at the behavior of the neuromuscular system, it becomes so complex that I think the best thing that you can do clinically is think about, what kind of activity do I need this person to do? And how can I replicate that in some type of rehabilitation setting? When you think about the direction or magnitude of the force or the rate of force development that's required. What do you think that's a reasonable comment?
Oh, absolutely. I 100% agree. Movement is really complex, and I think the best way that we can achieve, because there's so many things that if you think of, like, a clinician trying to incorporate all these concepts, and it's quite overwhelming, right? So I guess the best way of approaching this is just thinking about the demands that, whatever, if you think of a movement, a rehab movement, or sports, right, you just think about the demands that sport will require, and try to rehab in all those possible, for example, range of motions, and thinking, like, not just the active structures, but also the passive structures, and also, like, the interaction between them. So we need velocity, we need coordination, we need power, we need strength, we need all these different features to actually move in the most efficient way, particularly after pain. Yeah.
Before we move on to the next topic, one other thing I wanted to discuss with regards to looking at EMG and the sensory motor system is, when I think back to, say, the 2000s, there seemed to be a very big movement about this idea of motor control of using internal cues to quote unquote turn on a muscle. And there's a whole debate and discussion that can be happened about that. But you're obviously in the trenches with a lot of the researchers who started with this research. Have you seen that there's still a real emphasis on using types of cueing to try and change EMG behavior, or do you see that it's really evolved more to include a lot of different variables beyond that?
I think it has been evolving definitely towards like incorporating the other factors as well. EMG is, like as I said, it's just one piece of the puzzle, and I think everyone understands now that motor control is just more. It's not just about the muscle, and I do see that there is like a shifting towards like how we can better understand the whole system, but also like trying to identify like the pieces that are relevant. So that doesn't mean that we are like saying that that doesn't matter, or like that moving doesn't matter. It's just understanding how and how much matters, right? Like we it's not just about like whether you activate or not activate a muscle. It's like how you do it. Like, is that different from what you do typically in your daily life? Like how much you do it. Like there's so many other factors that can contribute to that. So yeah, definitely moving towards more like not a function. I want to say I hate that word. More like a
it's a very loaded term. Yeah,
it's such a loaded term. Like no one knows what that means. But more like understanding like holistic, I guess.
Speaking of loaded terms, well, no, the other one that I feel like gets thrown around a lot to mean lots of different things is activation.
Yeah.
I've just mentioned that then. And
Yes.
the reality is I think most physiotherapists think of activation as a muscle turning on. That to me seems very counterintuitive, because it feels like if muscles were turning off in the presence of pain, we wouldn't have got very far through the evolution of humans living in the natural world. So
Yeah.
for you as a researcher, how do you define activation, and how do you think we need to think about it clinically?
So we actually have a nice terminology paper from this consensus project, and we had to define muscle activation. There were so many people that opposed to that, but just because for the clinical world. But when we talk about muscle activation, we're mostly talking about the EMG, the amplitude of the EMG signal, right? But that doesn't mean that the muscle activation term is the correct one, because you're not actually measuring that. You're measuring like the electrical input from the electrodes. So it's not muscle activation really, like that. We can't really estimate that as a whole, as you said. Like it's such a vague concept. But when we talk about like in research, when people I think talk about muscle activation, they're actually referring to the EMG amplitude of the amplitude of the EMG signal. Yes.
Yeah, and I think that's actually really worth emphasizing, because it's obviously a term that's used in a research setting. And unless you actually have EMG analysis, which most of us don't clinically, I think it's something that I do get concerned that whether there are certain connotations associated with that term, and how that even affects patients you work with when you're using that terminology as well.
Yeah, like for example, let's activate this muscle. Like you need to do this warm up to activate whatever muscle. The muscle is gonna be acting, functioning regardless of whatever you do. So I agree. I think it's not well used in the clinical setting.
Is there any evidence along the lines of some sort of activation that it does improve the performance, or are those activities such as that people use in warm-ups, that they say they call them often activation exercises, but are they potentially even more related to, say, the peripheral environment, like increases in the temperature of the tissue and some of those enzymatic pathways do start to open once you actually start using that tissue specifically? Is there anything that suggests that activities that have high EMG activation patterns as per measured by EMG do actually lead to better performance of that tissue, and then consequently that tissue within a more complex motor task? Because that's the thing that I always think is interesting, is there'll be a lot of these isolatory type activation exercises, but is that actually translating to better performance in, say, a running task or a change of direction? I don't know, at least in my understanding, that leap has actually occurred.
Not that I'm aware of. No, I agree. I don't think there's anything like that. It's very tricky. The only thing that I can think of is there's a nice study done a couple of years ago, I think, looking more like the plyometric exercises. So there's a very simple task like jumping with a rope for, I think it was 10 minutes with bouts of like, I think it was like 40 seconds on, 20 seconds off for 10 minutes. And that definitely improved running performance. So I guess it's more about like, for me to improve, like it's so different to study, to investigate. But it depends on your previous level of like, exercise, whether you've had those type of exercise before. But if someone that hasn't done any sort of plyometric exercise and you're asking them to perform a activity which will require some sort of power, right, or speed, I think it's more beneficial to do some shortening and lengthening of the key muscles. So again, thinking more like as a whole thing rather than very specific, like activating the gluteus medius, because that will allow you to decrease the pelvic drop when you're like in the stance phase of running. I don't think that's the case. I don't think. Yeah.
No, and I think like probably the more important thing is when you think of specificity, think of specificity to task.
Absolutely.
As opposed to like the idea of an individual muscle that's involved in that task.
Absolutely. Yes, I agree.
Now, you've certainly done some interesting research in a few different areas, and one of the articles that you've done that came to my attention was looking at changes in the stiffness properties of the Achilles tendon and the soleus with changes in knee angle. Now, this seems counterintuitive at first because when you think about the soleus, it only crosses the ankle, not the knee, so you wouldn't expect to see changes in its stiffness when you extend the knee, as an example. Yet, in fact, some of the research you're involved in found that. Can you explain why that's the case?
Yeah, absolutely. So just before, this study was led by Carlos Cruz Montesinos, who's a researcher from Chile. So he kindly invited me to this research. And we published this in 2022 in the Journal of Electromyography and Kinesiology. And basically, we wanted to investigate like the influence, as you said, the knee and ankle joint positioning on the compressive stiffness of the soleus and Achilles tendon using a technique that's called myometry, which is a non-invasive and it gives you a surrogate measure of stiffness, which is also very important. Like we can't really measure stiffness in vivo at the moment, like directly. And what the study showed was that both the Achilles tendon and the soleus showed significant increases in the compressive stiffness with knee extension compared to knee flexion across all the ankle positions that were tested. So we tested 10 degrees of dorsiflexion, the neutral, which is considered 90 degrees, and 10 degrees of plantarflexion, neutral, and 10 degrees of dorsiflexion. And these changes in stiffness were related with the knee positioning and were more pronounced in the soleus and the Achilles tendon. So especially when the ankle was in a neutral position or dorsiflexion. So as part of that study, they also conducted a cadaveric dissection to provide additional insight into what could be the explanation for this. Like, as you said, the soleus doesn't cross the knee, just the ankle. So how can you see differences in stiffness when you move the knee? So this cadaveric dissection it was really interesting because you can see the close anatomical relationship and potential paths for myofascial force transmission between the soleus, the gastrocnemius, and the Achilles tendon, suggesting that their anatomical basis for this observed changes in its stiffness that we saw with the changes in the knee and ankle positioning. So the fascia is a really, like, one of the big, like the main function of the fascia is to transmit forces. So that's something that we typically forget. When we think about forces, we're only thinking about muscle and tendon, but the fascia has a really important role in transmitting forces as well.
What implications does that have in the real world when you think from a performance or rehabilitation setting? Because like when I think about anatomy, we typically see it in a very reductionistic fashion where we have muscles, we have this clear origin and insertion. But this throws that completely out of the water, where the reality is there is a lot of anatomical connections between synergistic muscles that then allow lateral force transmission and potentially longitudinal force transmission. So how do we need to think about how that influences what we do clinically?
That's a really good question. I think it comes back to what you said before. Like, we need to think about like the demands of the task that we want to rehab, and not think about like the isolated muscle, but we also need to think like the interconnection between these tissues. So if fascia will contribute to transmitting forces, we need to think about, like, of course, getting the strength and the power, but also that plyometric will affect the interaction between the muscle tendon and the fascia. So when I think about like all these anatomical factors, I always try to think, okay, how can I provide the most variable? You need to provide variability, because that's how you train all these different. Because the fascia also has different directions, so it's not just linear, as you said, or like vertical. So we need to understand that the ability to produce force will also depend on the direction on which you apply that force. So I try to think of, like, in a practical way, how I can translate this into practice is, well, you need to give variability and try to think of like all the different physical capacities or abilities that you need to train, and not just the activation. So it's not about just whether you move nicely. It's also about like actually getting that person to produce force, like in a good way, power, and all sort of like the different physical demands that person might need. Yeah.
It's an interesting concept. You just made me think of the fact that adding variability is likely to improve, say, robustness of a tissue to the external stresses and ergonomic tasks that you undertake. However, we live in a world now where everyone's trying to measure improvement, say, particularly through a rehabilitation or performance setting. And the more variability you add, the less likely you are to see, say, linear changes in someone's performance capability. So you're almost disincentivized to do more variable things, even though it probably prepares them for the task at hand, especially in, say, like a multilateral sport or something like that. So, yeah, I guess that's a statement, but you just made me think of that adding that variability is extremely important, yet it may not come up on some of our measures as being, oh, they've improved their power output in, say, a sagittal plane task.
Yeah, I think again it comes back to what you want to achieve, like for what purpose you're adding that variability. So that variability wouldn't be random, right? It would be like targeted to that specific movement. So I think we often forget like that the person needs to go back to their normal environment, and the rehab, at least from what I've seen, is typically like in the kind of first phase of like rehab, like the force is a equal, isometric force, like whatever, all these tests that we do, but it's actually the person like performing at the pre-injury levels. That's a different story in rehab and prehab as well, because you also want to try to avoid like recurrence of injury. So I guess my comment was more about like we need to think about the movement as a whole and what the person needs to do, rather than like just rehab like that muscle, that specific task or whatever. And I think adding, and again, this is more like my personal opinion, I don't think we have evidence for this, but I'm not sure if like adding variability will decrease performance in the end. Like I'm not sure.
No, I don't think it would.
Well, no, I think it's probably more reflective of decreased performance in like a measure such as doing like a single leg, a seated calf raise as an example.
Or isometric, force plate task or something like that, which is, unfortunately for us, we want these measures because it creates this idea of certainty around, say, return to play or something. 100%. But that might not actually be a nice correlate for them being ready, as opposed to, as you said, exposure to different variations of that task.
Yes.
That might actually be a better preparation, but we can't measure those things in a quantitative fashion in the same way. So we kind of lean on those tasks that we can measure, but maybe that's not actually getting what you want.
No, the other thing I think of too, then, like you mentioned too before, Manuela, is when you think of fascia, which the reality is when we have a strain, we often affect the fascial tissue as well. There are different layers that go in different directions. And so if you're applying, say, a seated calf raise as an example for the soleus, it's obviously applying forces in one particular direction. When it comes to running on the field, there's a lot of nonlinearity in terms of the angles and the positions of the ankle and the body, and how that loads not only the soleus, but then the surrounding connective tissue as well. So the importance of that variability to be able to apply forces in different directions seems really important to make sure that you're actually maximizing the tissue properties.
I agree. I think we need to, that's the key thing, maximizing the tissue properties based on the task demand, like the demands of that person, whatever that might be. And going back to your comment of like, how do we measure it? I think Yeah, I think we need those specific tasks to be able to, progress in our rehab. But there are also like other things that we can measure, like if the person was like running a certain time or pace or whatever, or doing whatever distance, like all those like general things. If you think of like, okay, if the person is doing sort of the same sort of activities that they were doing pre-injury, and also the confidence, like more like the psych measures that we could incorporate in our rehab. Like, do they feel like with enough confidence to actually be able to perform at that pre-injury level? So I think that would be like a way of that. At least I would do it. But I agree, it's really hard to measure, like if you incorporate all these different things. Yeah.
Changing topic a little bit, but nevertheless very interesting. You were involved in a research publication recently looking at the relationship between sleep and recovery. And this is an interesting topic because I think a lot of the time people will offhandedly say, oh, like sleep is really important, diet's really important. But this is a study that really looked at different physiological measures of what happens when you induce an injury and deprive, this is an animal model, them of sleep. Can you actually explain the study and what you actually did and what you actually found?
Yeah, absolutely. So again, I was kindly invited to be part of this project, and the
Don't be too
person
modest. It was all you. You came up with the idea.
No,
You
I
ran
You're
the
the
didn't.
study.
genius in the room here.
Yeah.
No,
You
I'm not.
self-funded it, everything.
So the person who led this project is actually a NHMRC emerging leadership fellow at UQ, so David Klein. He's been conducting amazing work around like the interplay between sleep, exercise, and pain, particularly the transition between acute to chronic pain. And also now we're investigating the fluctuation of pain. So this project that I'm currently working on, the low back pain flares, is one of the principal investigators. So in this study that you're talking about, as you said, we used a rat model to investigate whether poor sleep contributes to the persistence of pain and whether exercise can mitigate this transition, exploring like the underlying biological mechanisms that could be involved. So the study involved 29 rats that were subjected to an intensive lever pulling task for about 4 weeks to simulate this acute onset of overuse injury. So after the injury, the rats were divided into 3 groups for another 4 weeks. So the first group was voluntary exercise via a running wheel access. The second group was a sleep disturbance. And the third group was a combination of both. So we measured like a bunch of different outcome measures. So pain-related behaviors, systemic levels of, for example, the brain-derived neurotrophic factor, the BDNF, which is basically a measure of central sensitization and maladaptive neuroplasticity, which in turn could drive the transition from acute to chronic pain. And we also measure other biological markers like estradiol and cortisol, all those type of things. And what we found was that after the injury, the mechanical sensitivity increased across all groups, but remained elevated only with the sleep disturbance group. And exercise, with or without sleep, regardless of the sleep disturbance, were reduced the sensitivity to the pre-injury level. So that's pretty interesting and cool. And also the reflexive grip strength, which is also like a way of confirming that the rats had an injury, an overuse injury, also declined post-injury, which we would expect, but improved post-intervention, especially in the exercise group. And the final thing is the BDNF, this central sensitization marker, also increased with the sleep disturbance alone, but were normalized with exercise. So what this study tells us is that actually provides like the first evidence to that poor sleep could be may play like a causal role in the transition from acute to chronic pain, by possibly enhancing these peripheral and or central sensitization mechanisms. And basically what we also can take out of the study is that exercise has a really big, important role or a potential intervention to counteract the effects of poor sleep on pain sensitivity. So basically, by potentially reducing desensitization, exercise offers like this non-pharmacological option to mitigate the persistence of pain after injury. So lots of cool things, and now we're trying to investigate this in humans. So that's the next step.
Is
for
there
us.
been consideration to the type of exercise, like whether it's more aerobic in nature or say, a lifting task or something like that that's more anaerobic in nature? Does that seem to have an effect? Do you know?
Yeah, so that's it's important point. So this was an aerobic exercise, and that we do think that aerobic will have like a greater impact than like a strengthening base, but we don't know yet. So it's hard for rats to do an anaerobic exercise. So the only exercise that we can do is just running on a wheel. Yeah.
Or you could have a resisted wheel.
Yeah, maybe. Yeah, true. Yeah, that could be a good model.
Can I ask why you believe it might be more beneficial to do aerobic? What is there certain mechanisms that give you that inclination?
Yeah, we don't know yet. Like, that's a really good point. We don't know because we know that the exercise is mediating this path, right? But we don't really know, like, inside what actually doing. We believe that it's affecting the BDNF, right? Like in the long term. But how it does it, like by which mechanism the aerobic exercise does that, like we don't know. So it could be that other type of exercises will have an impact. We're hoping to have more answers to that after this big project that we're currently running in humans.
The thing I took from the study that was really valuable is this relationship between local tissue damage and systemic markers. Because I think, obviously as a general recommendation all the time when you have, say, acute low back pain, it's recommended to continue to do some form of physical exercise or activity. And I think it's something that a lot of people, both clinicians and patients, don't appreciate, of trying to maximize systemic health through being physically active, through maintaining good sleep hygiene and quality, because how that influences your physiology actually has an impact on the local tissue environment and the recovery process.
Yeah, absolutely. I think the sleep is a big beast as well. Like we know that we should sleep well, but we actually don't do anything about it. Like even like I know all this research, and I go to bed with my computer, I watch Netflix, connected to my phone, I do all these like awful routines that you shouldn't do. But I think that's a really cool thing, that we know that sleep could affect sensitization via these biological markers, right? So and then physical activity is actually counteracting this effect by affecting or probably improving or managing the increase of the spike of the biological markers. So and therefore will have an effect in central sensitization. So I think the combination of both for like clinicians is so important. Like first detect if there are sleep issues like sleep impairment or sleep disturbance. So whether you're sleeping bad, but also the effect of sleep on the next day. So your quality and how you're performing, and knowing that exercise, even like the smallest bit of exercise, could probably have a positive effect on your the bad effect that sleep has on your in your system when you're in pain.
It makes a lot of sense too when you think about the prevalence of low back pain, and particularly long-term low back pain, is getting worse and worse. Most pain seems to be very non-specific in nature, yet we still seem to apply a purely very mechanical lens to looking at back pain in terms of like biomechanics and strength, which, not to say that they aren't relevant markers, they are, but it seems that there's so much more research suggesting that other indicators of your overall systemic health, and sleep and exercise are good examples, seem to have such a strong correlation to the outcome of back pain as well. And it seems that like back pain can almost be an indicator for a lot of people of chronic disease, similar to things like cardiovascular disease or type 2 diabetes. I mean, that's just my opinion. You might disagree with that, but it just seems to be that we need to be a lot more holistic when we think about overall general health markers of individuals who present with non-specific low back pain.
Yeah, I agree. And I think what we're trying to do now is trying to understand what treatment fits the right person. I think we're not there yet. So it might be that movement related things are more like beneficial for some specific people and more like side measures to other people, and maybe sleep and other behavioral stuff. I think we're moving towards like finding the right treatment for the right person in the right doses at the right time, which is really hard. But I think that's where we're moving now. But by all means, doing general things that we all know that works for like general population, like sleep, physical activity, nutrition, do the basic right. I think that will, cover probably the 80% of your rehab plan if you do the basic right, and then try to manage the specifics. That's my personal opinion.
It sounds like we need to get better than at understanding human psychology and behavior because, they're often the biggest barriers to actually seeing improvements in a lot of these types of patients to create those behavioral lifestyle changes.
Absolutely.
What's next on the horizon for you? Are you involved in any other research topics in completely different areas of what we discussed today?
So besides what I just said about like low back pain flares, which is pretty novel as well, because one thing is the transition between acute to chronic, but we don't really know what makes someone worse when they already have low back pain. So we are investigating that at the moment. It's a pretty big, like a 5-year project. So we probably won't hear much about it like in the next few years, but hopefully like after that. Besides that, and we're also like applying very cool measures in the real world, like measuring like sleep quality with pretty cool equipment and movement, and we're doing like blood collection and saliva for cortisol, like all these different measures that hopefully will give us a better idea of this holistic problem. And besides that, we're running a couple of studies in running, looking at self-regulation strategies in running injuries. So we're currently recruiting people, runners with and without injuries that self-classify themselves as injury prone or injury resistant. So I'm very passionate about like we always study why people get injured, but we don't really study why people don't get injured, right? Or what makes someone be so
Robust.
Exactly, robust. That's the word. Yes.
I think that, sorry, I'm jumping in,
It's okay.
but like, I don't know if Jack shared this with you, but I coach track and field at a high level. And one of the big things that I get really frustrated with is there's a huge concept of people getting excited by people with talent. But often a lot of these talented people have a lot of injuries, right? And they always talk about the fact that, oh, they're so talented if they could only get their body right.
Yes.
And I often bring up the exact thing that you just said. Maybe some people's talent is not that they can perform at a really high level, but they're so robust that they can train their way to that level. And we don't see that robustness is in itself their inherent talent. And studying those people, I think that you've touched on something, and I probably haven't shared this with people, but I actually think that there is a really strong association between psychological factors and the way that they view what they're doing and what they're trying to achieve and getting injured.
Yes.
With some of my athletes, for instance, if I say to them, we're going into a heavy training period, where the volume or the intensity or both are going to be a little bit higher than normal, some people will see that as the perfect opportunity to improve, and some will see that as the perfect opportunity to start complaining that they're tired and sore and I've just got to get through this and I don't know if I'm going to cope. And straight away, those people are very quick to start reporting, oh, this is sore, this is tight. And I think, have you actually perpetuated this situation because the way that you came into it was one in which you were scared? I apologize for jumping in, but I think that you're very much hitting on something that I think is that there are people who don't get injured because they almost don't even conceptualize the idea that they can get injured. They're not considering it as an option. Whereas people who have been injured see that there's danger at every single turn. And to me, at least, it does seem like it contributes to them developing injuries in the first place.
I 100% agree. I think it's fascinating, at least to me. I think we need to study more those robust people. And there are a couple of things like mental toughness and passion, as you said, like a psych and behavioral factors that could, I think, contribute greatly to whether someone is experiencing an injury. And it's so hard because there's the pain is a perception, but also you have like tissue loading, like the actual,
mechanical
damage,
load,
mechanical loading, and also all these fears and things like will affect that perception. So it's really hard to understand. So I think like if we study people that don't get injured, like, or at least haven't had an injury in the past year or two, versus someone who has like at least 1 or 2 injuries in the past year, like recurrent versus injury resistant, like if we can call it them like that. And we study like what are the key features of that, like what these people do to actually be injury free, like what are the strategies. And I think this self-regulation strategies, coping, all these psych things that person could incorporate will make a huge difference. So we're doing this mixed method studies, a quantitative survey looking at all these psychological factors, but also we'll be interviewing people to further understand what they do, how they do it, what they think this is important or not, you know. So if you don't mind, I'd be happy to share the once we start the study with your team. That would be great to have.
I always think about it of like some you present, because it's interesting. Often I'll present the exact same information to 2 different people, and these are adults, but you see very clearly one sees this as an opportunity, one sees this as a risk. And the way you have to actually manage their expectations and how they get through that period is so different. And it can be very frustrating because you're saying like your teammate who you're at a similar level to in terms of performance is seeing this as a great opportunity to get better, and this one is seeing as like, I'm so scared that something's going to go wrong, and it seems to self-perpetuate. So
that's so interesting.
I think it's a big factor that it's really cool that you guys are exploring this, because I think it's going to show some very interesting new information.
That's cool. You made me think that we should probably interview coaches as well, because they will have like a whole different perspective on what's going on with that, you know. So we might incorporate that as well, because we're only looking at from the runner's perspective. But be also cool to see what coaches think is happening.
Definitely.
Yeah.
Well, thank you very much, Manuela. You've mentioned that you do research in lots of different fields. Outside of your professional work, do you have any other particular interests or passions that you're pursuing at the moment?
Well, I'm a very passionate runner myself. That's why I research on that area. And I'm currently training for the Gusler, which is an ultra trail race here in Brisbane, the 50K. I'm a new mum, so my daughter has like less than a year. So it's a very big challenge for me to try to train and push my limits while also keeping the expectations low, because my fitness level before being a mum was like here, and now I'm like, I can't even like show you where am I, but so that's what I'm currently working on from a personal level.
You should take confidence from Australia's super mums that are doing really well in the marathon. We've got 4 of them that I think are mothers that are probably our top 3, 4, 5 marathon runners. So don't be scared. I think the performance seem to be getting better and better, and some of them are well into their 40s. So
I know, I've seen that, and I think, you know what, I think it's like being a mom exposed you, or like the whole experience exposed you to like so many things that I think you can push yourself and tolerate more pain, way more now than before. Yes. Yeah.
It's a concept that, Jack and I have been discussing a little bit recently, but I think it's anything that introduces you to new stressors, and some of them are psychological, some emotional, some physical, sleep deprivation, all of these things, as you said, expands your envelope to be able to deal with, problems that are in front of you. So all of a sudden you see something like a 20K run as a training run as a much smaller problem than what it was, pre-child. You're like, oh, that's easy. I'd rather deal with that than sleepless nights. I do think that it really expands what you believe you're capable of, and that in itself is a huge strength that you gain from parenthood in general.
I agree. Yeah.
Well, thank you very much for giving up some of your time to come on and talk to us about all the really interesting and diverse things that you're doing in research world.
Thank you, Jack. And I'm sorry that I called you James.
No, it's good. From now on, I'm going to be calling him James as well, and he's going to hate it. So thank you, Manuela. You've given me years of ammunition now.
I'll never hear the end of it now. Never hear the end of it.
True. No, thank you so much for inviting me. I really enjoyed this conversation. I hope it was helpful.
No, thank you.
Definitely.